Yeah, we are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 28 of Amogs, Emergency Obstetrics Committee with OGSH. So it's my privilege to introduce the convener of today's webinar, Dr. Manjula Rao ma'am. Ma'am is the secretary of OGSH, senior consultant and HOD of OBGY, Durgabai Deshmukh Hospital, Hyderabad. I welcome you, ma'am.
Thank you, Sahiti. And thank you, Sahiti. I thank Dr. Sneha Bhuyar for this opportunity. And I also thank Dr. Manjula Rao, who is the Secretary of Obstetrics Society, Hyderabad, for this opportunity. I extend my warm welcome for this webinar. And it's my privilege to introduce Dr. Sneha Bhuyar, who is very dynamic and hardworking. She's done a lot of work when she was in breast health committee when I was a joint secretary. And she's an International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award 2021, SN Malhotra Individual National Award for Outstanding Work in Rural Obstetrics, Durusha Distinguished Community Service National Individual Award Champion of Foxy Award for 2 consecutive years, 20 and 21, Dhira Award for 22, Anandi Bai Joshi State Award for Government of Maharashtra, Lokmat Health Excellence Award 2020. She's got many talks, keynotes, orations. She has moderated many panels and she's written many books. I welcome you, Dr. Sneha Bhuyar, to take the webinar forwards.
A very good evening and a warm welcome to all. My respect and regards to all the seniors here, and I take this opportunity to welcome all the respected senior members from OGSH, and of course, thanks to the President, Dr. S. Shantakumari, who is right now busy, but yes, she has blessed our program and all of us. Secretary Dr. Manjula Rao. I thank the team of Amogs, that is Maharashtra Association of Obs-Gynae Society, the President Dr. Kiran Kurtakoti, Dr. Bipin Pandit, the Secretary, and the Treasurer Dr. Madhuri Mehendare, the immediate past President Dr. Rajendra Singh Pardesi, our guest of honor Dr. Ashwat Kumar, our speaker for today's program, our dear friend Dr. Girija Wagh, who is an illustrious speaker and very knowledgeable personality, and of course a strict administrator, Dr. Aruna Suman, our dear friend, of course, professor, and we are very eager to see her in a responsible position. And best wishes to you, Dr. Aruna. I also welcome Madam Vindhya Tirumala Reddy, and of course Dr. Padma, Dr. Kiran Mai, our dear friend, Dr. Lakshmi Tirumamila, and my dear panelists, especially Dr. VP Josna. I think she has conveyed her inability to join, but Dr. Sarada, Dr. Shanti, Dr. Anita Sidhu, Dr. Archana Singh, and Dr. Mahalakshmi. I welcome all of you and thank all of you from the bottom of my heart. Special thanks to OGSH for having this program, getting organized at the last minute with so much of cooperation for all of you. A special thanks to you, Dr. Manjula, and of course, Aruna Suman and Kiran Mai. And with this brief words, I would hand over the forum once again to Sahiti. May we just have the prayer before starting the academic session. Sahiti, can we have the prayer, please?
Yes, ma'am.
Kurutvang kalyanam arogyam dhanasampada shubham kurutvang kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvang kalyanam arogyam dhanasampada शुभं कुरु त्वं कल्याणम् आरोग्यम्
So with the blessings of God and the respected seniors, we would like to go ahead with the academic session, and I would like to introduce the first, chairperson for the first session, Dr. Vindhya Tirumala Reddy, who I hope Madam has joined. She said she's busy, but she will join from somewhere. So let me just take this opportunity to introduce Madam. And she was she's the senior consultant of Obstetrics at Apollo Health City, Hyderabad, and Vice President of Telangana Obstetrics Society for 22 to 24. Of course, she has held so many posts, and we know her personally, a very gentle human being and a very helping hand, easily accessible. We're really thankful to you, Madam, for accepting the invitation. The next chairperson is Dr. A. Padma Kumari, who is also the consultant at Omni Hospitals, Hyderabad, participated as faculty chairpersons in various conferences of ISAR, FOXY, and of course, she has also delivered so many talks. She has so many awards and inspiring, gynecologist of Hyderabad by ET Health World 2019, and she's a life member of FOXY. We welcome you, Madam, and over to both of you for introducing our dear speaker, Dr. Aruna Suman, who will be speaking on sudden maternal collapse. Over to you, Chairperson. Yes, Madam Padma, please unmute yourself. Click on the mic icon.
Yeah.
Yes. Good evening.
Dr. Aruna Suman, she is a professor of Obstetrics and Gynae, Government Medical College, Jagatyala, Telangana, and Joint Secretary for FOXY 2021 and AACBUZ Hyderabad 2024 Organizing Secretary, National Coordinator, No to War Committee, and Practical Obstetrics Committee FOXY member 2024 and 25. South Zone Coordinator FOXY 2022 and 23. And Adolescent Health Committee FOXY member 2016 and 2018. Vice President of OGSH 2022-23 and TCOZ.
Thank you, Dr. Padma. Let us continue with our program,
yes.
academics.
Okay. Okay, Aruna.
Yeah, I'm sharing my screen. Hope you are able to see my screen.
Yes.
Yes. Thank you, Dr. Sneha, for giving me this topic, but really a difficult topic. I think I will do justice for it. Sudden maternal collapse. Sometimes it's very difficult clinical situations. We have faced many maternal collapse, which is very difficult to diagnose. Suddenly, when there is pulseless, BP-less woman who is in shock, it's very difficult to take over. You're in shock first. So you will have to have the proper knowledge about the maternal collapse and the resuscitation, various causes of maternal collapse. Maternal collapse is an acute event involving the cardiorespiratory system, brain causing reduced or absent conscious level at any point during pregnancy up to 6 weeks. So actually the collapse is not a reported event. So we don't know the true incidence that occurs. So it can be up to 6 in 1,000 births. However, wherever the death has occurred because of poor resuscitation, many of the maternal audit says, it represents acute illness with multiple etiologies. Is there a possibility to identify and manage the case? Yes. Understand the issues related to the maternal collapse, learn how to do proper resuscitation, achieve competence on those skills. An obstetric modified early warning score, MEOS chart, is very, very important in identifying the deterioration of the physiological parameters, where we can identify the woman who is going to be at risk for maternal collapse and alert everyone, and we can manage properly with our skills. What are the various causes? So it can be thromboembolism, amniotic fluid embolism, anaphylaxis, hypovolemic shock, and heart failure. These are the few causes. Reversible causes, are 4 H's: hypovolemia, hypoxia, hypo or hyperkalemia, hyponatremia, and hypothermia. This could be because of bleeding, PPH, where there are the cardiac events, peripartum cardiomyopathy, hypo or hypovolemia, hypokalemia, and hyponatremia because of usage of oxytocin, and 4 T's: thromboembolism. This can be because of amniotic fluid embolus or pulmonary embolus, air embolus, or myocardial infarction. Toxicity because of any drugs, and tension pneumothorax or tamponade because of trauma or suicide. And one more E is eclampsia and preeclampsia. The maternal mortality now is more not because of postpartum hemorrhage. We are able to manage the postpartum hemorrhage better. Now it is because of the rising medical disorders in pregnancy. The heart disease remains the leading cause of death, followed by thrombosis and thromboembolism, and the next, even the suicides of the mothers. So that there are direct or indirect causes of maternal death. Direct obstetric death because of obstetric complications of a pregnant woman, like pregnancy, labor, postpartum, related to the pregnancy. Indirect obstetric deaths are because of indirect obstetric causes like pre-existing diseases, medical diseases, or these will aggravate because of the physiological effects in the pregnancy, so that it will cause the maternal mortality and death also. The cardiac disease remains the largest single cause of indirect maternal deaths. There can be thromboembolism, suicides, etc., as I told you. Coming to hemorrhage. This can occur any time during pregnancy, like from the beginning of the pregnancy because of ectopic, incomplete abortion, or any kind of antepartum hemorrhage, like placenta previa, placental abruption, uterine rupture, and it can be concealed or revealed hemorrhage. So prevention, prediction, management of each case that we have identified. So first of all, we have to diagnose the disease and you have to manage it properly. Coming to amniotic fluid embolism. So working at a government maternity hospital, we have seen many certain kind of sudden deaths, which we couldn't find the reason. And there are no facilities to do the investigation. So we would put the diagnosis like amniotic fluid embolism. Whenever we diagnose the patient as amniotic fluid embolism, we could not resuscitate the patient. The incidence is said to be 67 per 1,000 births. It will occur immediately 30 minutes after birth. Once when we were doing rounds in the labor room, we did ARM and suddenly the woman collapsed. We couldn't resuscitate her and we put the diagnosis as amniotic fluid embolism. The other cause is thromboembolism. This is 15 to 24% of the women with untreated DVT can experience this pulmonary embolus. So always there should be a team to assess the collapsed and shocked women who are pregnant or in the puerperium, where the clinical diagnosis is clinched and is managed properly. This is the algorithm which is showing the management of thrombosis during pregnancy. Coming to sepsis. Although the true incidence is unknown, conservative estimates indicate that sepsis is a leading cause of mortality and critical illness worldwide. The most common organisms implicated in obstetric sepsis are streptococcal group A, group B, group D, and pneumococcus and E. coli. So how can we identify a case of sepsis during pregnancy? It's very, very difficult because the physiological changes are always masking and the diagnosis is very, very difficult. So using the MEOS chart or a modified obstetric SOFA scale, we can definitely identify. So what does the new bundle says? There was a bundle of 6. Now it is gone. The updated bundle is 1 hour bundle. So if there is a clinical suspicion, identification, the management should be proper. 1 hour bundle, cultures prior to antibiotics, lactate measurement, broad spectrum antibiotics, crystalloid fluids, and vasopressors. Investigation should be done. Procalcitonin helps in the diagnosis and guide of microbial use and source control. The source of infection should be definitely removed. The fetal heart monitoring should be done. And now we are not concentrating on the fetus, but the maternal life is more important. The complication prevention, like early enteral feeding and initiating the DVT prophylaxis, avoiding hyperglycemia above more than 180 is important. Drug toxicity and substance use. So substance misuse is there where the women can collapse. So taking proper history, admitting her, doing investigations is important. And magnesium sulfate can cause toxicity. Once during my duty, the senior resident and the junior resident both have given the magnesium sulfate. There was a cardiac arrest. Immediately we have called the anesthetist with intubation and ventilatory support. We could save the woman after giving this 10 ml of 10% calcium gluconate. So definitely there can be a drug toxicity. Eclampsia sometimes is a cause of maternal collapse. This is preventable. Improper treatment of preeclampsia can lead to eclampsia, and this is definitely can be managed with magnesium sulfate, intramuscular or intravenous, according to the your hospital protocols. There can be an intracranial hemorrhage because of uncontrolled hypertension, ruptured aneurysms, or arteriovenous malformations. We should remember anaphylaxis. This is a life-threatening, generalized, systematic hypersensitivity reaction resulting in respiratory, cutaneous, and circulatory changes, possibly gastrointestinal disturbance and collapse. This is a real emergency where we need to tackle. The 3 criteria for anaphylaxis is sudden onset, rapid progression of symptoms, life-threatening airway, breathing and circulation problems, skin, mucosal changes. There can be urticaria and angioedema. So readiness of the facility, crash cart, and skilled staff who are available 24/7 is important. There should be a quick response. Definitely, early diagnosis should be there. And this can be managed with adrenaline and other drugs, hydrocortisone and chlorpheniramine. There can be other causes of shock, hypocalcemia, hyponatremia, metabolic electrolyte disturbances, airway obstruction, and many causes. Now we know the causes. How do we do the maternal resuscitation? So definitely obstetrics life support. We all should know how to resuscitate the woman when she's pregnant, because definitely we all can face this problem because this is a real emergency. So we should remember the circulation, airway, breathing, and defibrillate, deliver the fetus, and epinephrine. These are the few guidelines. What are the basics in maternal resuscitation? From around 20 weeks of gestation onwards, the gravid uterus reduces venous return in the supine position. As a consequence, there's a decrease in cardiac output, which is 30 to 40%. So when cardiopulmonary arrest occurs, chest compression are needed to produce the cardiac output, to maintain the proper cardiac output. So we have to do proper, the ioto cable compression further reduces cardiac output to approximately 10%. Therefore, cardiopulmonary resuscitation is less likely to be effective in a woman who is 20 weeks or more gestational age. So what are the exact life-saving measures? So assess the signs of life, call for help. Manual displacement of the uterus to the left is effective in relieving ioto-cable compression in the woman about 20 weeks of gestation, or where the uterus is palpable at or above the level of umbilicus. This permits effective chest compression in supine position in the event of cardiac output. So how do we go about? Arouse the patient. Say, hello, how are you? If no response, call for help. Assessment of the conscious level. A, alert. B, respond to voice. P, respond to pain. U, unresponsive. Can also use Glasgow Coma scale here. There should be a team of experts. Always our hospital should have a code blue or emergency response team, where they will be alert and they come and help us during the emergency times. So there should be a left lateral tilt, perform 15 to 30-degree tilt. The main aim for the tilt is to relieve the iotocaval compression. So there can be increase in the cardiac output, which is 30 to 40%. So how can we do this? Or you can pull the uterus to the left side and start resuscitation. We all know about the oxygen supplementation, 10 to 15 liters per minute. We have to use 2 wide bore cannula for the circulation. And coming to the resuscitation, coming to the chest compressions, it should be 30:2. 30 chest compressions at the rate of 100 to 120 per minute should be performed for every 2 ventilation breaths initially. Once the patient is intubated, this is desynchronized. That means the ventilation should be at the rate of 10 breaths per minute with continuous chest compressions of 100 to 120 per minute. Coming to the perimortem cesarean section. In women over 20 weeks, we need to do a perimortem cesarean section if the CPR within 4 minutes of maternal collapse and there is no response. We have done proper CPR. After 4 minutes, there is no response. We can continue doing perimortem cesarean section. No consent is needed. We need not shift the woman. And suturing is done only after resuscitation. We can pack and keep it and start resuscitating. So it should be simple and more rapid access should be there. The best incision to use is midline abdominal incision, and classical uterine incision will give the more rapid access. After resuscitation, the proper teamwork, clinical governance is important, like proper documentation, incident reporting, debrief women if alive to the family or the staff members, and even if some catastrophe occurs, we'll have to talk. All maternal deaths should be informed to concerned authority, maternal audit at all levels, and no blame game should be there. Always there should be skills and drills, because we all should know how to resuscitate a pregnant woman, and including the midwife, ANMs, ward boy, everyone. Every healthcare provider in the hospital should know how to resuscitate the woman, maternal resuscitation. This is an algorithm showing the resuscitative methods, whatever I spoke. So coming to the mental health. Maternal mental health is very, very important, because the suicides of the mothers after delivery or during pregnancy are growing. How can we prevent? 5 action steps for helping someone in emotional pain. Ask, are you thinking about killing yourself? Keep them safe. Reduce access to lethal items or places. Be there, listen carefully and acknowledge their feelings. Help them connect. Call. There are some helpline numbers they can call or we can call. Stay connected. Show some empathy towards them. If they are on any drugs before pregnancy, counsel them. Change the drugs which are compatible with the pregnancy. During pregnancy, they might need a help of a obstetrician as well as a psychiatrist. Postpartum blues during breastfeeding also, proper care should be taken. So yesterday I have seen this by WHO, the mental health check-in, where we check the pain in the woman. This is the diagram to show if the woman is happy or she needs support. So maternal audit is very important, and every hospital should have it. Ensure accurate documentation, debrief patient and relatives, other staff support and debriefing, review case through clinical governance process. The chain of survival is early recognition and activation of emergency response system. Perform CPR with a focus on chest compression, defibrillation, advanced resuscitation, post cardiac arrest care. And this is very important, and we all should be developing or enhancing the skill of maternal resuscitation. Thank you so much. And I request you all, my humble request, please support and vote for me for the Practical Obstetrics Committee Chairperson. Thank you so much.
I would request the Chairperson to make few comments. Dr. Padma, if she is there. Otherwise, I would also invite, yes, is she there, Dr. Padma?
No, she's not there.
Okay,
I
okay.
think she lost connection. Yes.
Okay, I invite few comments from Dr. Girija Wag, who is a very knowledgeable and very illustrious speaker whom we look up to. So we request few comments from you, Girija. Dr. Girija. I think I need to call.
Dr. Kiran will say something about that.
Yes.
Yeah, Dr. Anita, I can see.
Yes, Dr. Anita also can give comments. She's a professor from
Yeah.
Nilofer Hospital. Dr. Anita?
Disturbance is there.
Anita, your voice is crackling. You need to adjust your mic.
Not quite. Not clear, Anita, not clear. No, no, no.
Please unmute.
Okay, I'm sorry, I was not muted, unmuted. So I think Aruna, you gave a very wonderful, way of the maternal collapse. And as we all understand, this can be such a sudden happening. And there are a few things that we require to understand through the cardiovascular changes, especially in context with pregnancy. Having said that, I would always want to definitely stress upon one fact that we cannot always get under the excuse of saying that we are very loaded with practice and we don't have time to look at patients. Always a primary proper assessment, cardiovascular, we have to behave like a clinician. We are not midwives. We are definitely obstetricians who are specialists already in their field. And therefore, every woman who comes to us, a primary assessment by one of us, if it's a team or at least by you yourself, has to be done. So that such kind of things are predicted, if not avoidable. We should be able to predict them beforehand. They do occur suddenly many times, but many a times there is always, if you go into kind of a reverse analysis, we find that yes, there was a problem which probably we did not pay heed to. And that's one thing. And secondly, any type of iatrogenic challenges we should definitely avoid, because sometimes I am seeing across either through now webinars we are discussing, many times unnecessary medications are given to the patient, kuch to diya jata hai, and then there is fluid overload, there is embolus, there is anaphylaxis. Unnecessary interventions will never be able to protect you.
Yes, reducing human errors is also important in quality care.
Quality care, absolutely. Thank you so much. Wonderful.
Thank you.
Very nice, Aruna. You have covered everything. One thing is, having these early warning scores also helps, because we think patient has suddenly collapsed, but she does give some of the warning signs which we are not generally able to pick up, because she appears apparently normal. We had a case in OPD last 2 weeks back who was like not very breathless, but her oxygen saturation was showing 85%. That was later turned out to be a case of Eisenmenger's complex, who was accustomed to that kind of hypoxia. So the symptoms were not correlating with the oxygen saturation that we were seeing. So all the vitals, early warning score, everything, because pulse, many times pulse is like, the patient looks like very normal, but the pulse tells another story, the tachycardia or the bradycardia. Thanks, Aruna. Wonderful.
Thank you, Kiran.
Aruna, I think you need to tell
All right. See what happens is
Anita ma'am, your voice is crackling, ma'am. It's not
I think
clear.
maybe you need to log out and then join again.
you join it once again. That's
right now.
we now go ahead with the second session. Sahiti, can we have the CVs of the chairperson by the time? Yeah, I think we request Dr. Anita to check her audio, her device audio, and maybe she can log out and log in again, please. So we have the chairperson, Dr. Kiranmai Devineni, whom all of us know as the Foxy chairperson of Violence Against Women. And of course, wonderful job she's doing through this committee. Really, I mean, everybody must be thinking what she's going to do, like how people talked about my committee, breast committee. But I'm so happy that, Kiran is doing wonders to this committee. So, Professor Dr. Kiran Mai, she's the professor in GMC Vanapati and the College University of Health Sciences, and of course, the various awards and accolades to her credit. We are looking forward to you as chairperson for this session, Kiran, and welcome to you. We have Dr. Lakshmi Chirumamila. Yes, welcome. So we have Dr. Lakshmi Chirumamila, who is the Fellow of Royal College of Obstetrics, London, and infertility specialist, reproductive endocrinologist, and clinical director of senior consultant in reproductive medicine, Nova IVF Fertility Clinics. So welcome, Dr. Lakshmi. Has she joined? I can't see Dr. Lakshmi, but over to you, Chairperson.
No, she didn't join.
Okay, Dr. Kiran Mai, over to you for introducing our speaker.
Actually, it's a real privilege to introduce Dr. Girija Wagh, madam. She's not only our vice president now, but we have been looking up to her whenever, the academics, we talk of academics, we talk of passion, commitment. And as vice president, we are getting to know her much more. And she comes across as a very, very jovial, very cordial, and very cooperative person who loves to share her knowledge and pass it on. And we also know her passion for obstetrics, of course, maternal issues, everything. But her special interest is gestosis, hypertension, the complications of hypertension, and the screening, prevention, and etc. So, madam is the HOD of OB/GYN department of the very prestigious Bharati Vidyapith Medical College Hospital, Pune. And she was the chairperson for the Medical Disorders and Pregnancy Committee. She's a vice president of India Chapter Gestosis and a member of Governing Council ICOG. She was FOXI Joint Secretary to Dr. Sanjay Gupte sir in 2010. And she's the coordinator for the National Eclampsia Registry and PCPNDT Act member of the Central Committee. Of course, being the teacher that she is, she's a national mentor for programs like Laksha, the quality improvement for the Ministry of Health and Family Welfare. And again, Anandibai Joshi Award for Excellence in Medical Services. Madam, we welcome you to Hyderabad, virtually though. And it's a great pleasure to have you. And I think everybody is eager to listen to you.
Dr. Girija, please unmute.
सॅटर्डेला परवा ब्लिडिंग असेल
चालेल.
पण ते काहीतरी असं असतं ना, रुबेला वॅक्सिन घेतलं तुम्ही
1 महिना.
प्लॅन
1 महिना.
1 महिना.
Okay, can you see my slides?
Yeah, you need to, ma'am, you need to put it at, slideshow.
Yeah. So thank you so much for giving me this opportunity to, especially, Hyderabad society is like home for me. And all of you always love me so much that I'm grateful to Sneha for getting this kind of a thing which is very close to my heart. And I must tell you, Kiran Mai and Aruna, especially sometimes when we keep on having many webinars, CMEs, talk sessions, every time we feel that we have delivered. And then still when you go again at a new place or a new session, there are again questions of similar kinds. So this just keeps on telling us that we have to go on working and keep on talking and keep on learning ourselves. Because every session which happens like this is a learning experience even for us. Like today, I learned a lot of things from what Dr. Aruna spoke, and also I learned a lot of things from the questions that came from Kiran Mai. So, and we always should never lose our self-esteem. We are doing a very good work. We are going good work for women's health. And therefore, I want to wish all of you a very huge success in all the endeavors that you take, and request all the audience to ensure that these 3 queens are supported and they win those elections and they are there at the forefront, because finally It's all about academics at the end of it all. It's all about women's health, and that is where we all have to stand. Not the entire Foxy cannot represent each one of us, but the ones who are wanting to, we should support them. So let's come to the topic. Eclampsia, as we
Sorry to interrupt,
Please.
ma'am. It's not in full screen,
Yeah,
ma'am.
please put it in the
full screen
full
nahi hai?
slide mode.
No,
नहीं
ma'am,
है,
it's gone.
slide sorter दिख रहा है.
Slide mode.
Okay, I'll again share it.
Slide show. Yes.
Okay. Now?
Now
Yes,
it's
ma'am.
fine.
Yes, perfect.
Okay, yeah. So eclampsia, as we understand, is a new onset generalized tonic-clonic seizures or coma. Sometimes patient may not come with seizures. She will come comatose, or she will come with some vague symptoms, and she may have had convulsion which was not diagnosed. And it is typically associated with preeclampsia. And one has to look for whether there is HELLP syndrome alongside, because that is one of the representations. But also one has to understand that sometimes even with gestational hypertension, women can still have a convulsion. Now, despite advances in detection and management of preeclampsia, eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions like our country. Because when we are practicing in our centers, we find very rarely it will occur. Of course, it occurs once in a while when we have missed to identify certain things, or it may occur as a sudden lightning. But all the same, it is equivalent to inadequate care and care with less quality. So we have to therefore continuously be looking at this kind of futility without ego and keep on learning about this eclampsia. Now, what is pathogenesis? We all know that preeclampsia happens because there is no widening of the maternal spiral arterioles at the time of implantation itself. And today, the recent research is telling us that it is not only an inactive trophoblast which is not able to look into the spiral arterioles, but it is now being seen that there is some resistance which is coming from the decidua of the mother. And this resistance can be in the form of inflammatory processes in patients of obesity, diabetes, hypertension, or maybe some sort of an insufficiency, deficiency. And therefore, there is a whole lot of understanding that if we focus on every opportunity where woman comes to you for preconceptional care and are able to take away whatever we can take away and try to improvise whatever we can, we will be able to ensure that at least this part of her implantation is taken proper care of, wherein you can see that if it is improper, it is a hypoxic trophoblastic tissue which is going to keep on giving lot of noxious elements into the body and finally resulting in end organ involvement in the form of hypertension, endothelial dysfunction, proteinuria, HELP syndrome, abnormalities in the various systems, and cerebral edema, seizures, and PRES. Now, so therefore, friends, when we see an eclampsia, when we see an HELP, when we see a hypertension, that means there is a lot of problems which have happened there, which are like this, which are here. And what is clinically seen is usually something all just on the top, because there are a lot of other things which are happening below. So it's very, very curious to know why seizures occur in eclampsia or hypertensive disorders of pregnancy. And there has been a whole lot of discussion about why this happens. It is popularly believed that it is because of cerebral vasospasm and cerebral edema. And it has been argued that it is not the only reason. There is uteroplacental ischemia, which we have now understood, which causes release of certain molecules such as neurokinin B, inflammatory cytokines, endothelins, and tissue plasminogen activators, which stimulate excitatory neuronal receptors and alter the neuronal excitability, synaptic transmission, and neuronal survival independent of any vascular effect. And therefore, as I've been telling you about inflammatory process, and that's the reason why we believe in adgestosis, that it is some sort of an abnormal inflammatory response to pregnancy, which is the reason why this name looks appropriate rather than calling it preeclampsia. Because every time patient may not land up in eclampsia, but that always has to be a context. And in the current scenario, much focus has gone on eclampsia. We are seeing that much women are presented even with HELLP. So eclampsia happens to be one of the CNS complications, and various CNS complications also can be at the bottom of an eclampsia, like intracranial hemorrhages, infarcts, cerebral edema, press, and blindness. And if there is an intracerebral hemorrhage, it will require immediate reversal of any coagulopathy, as well as the discontinuation of anticoagulant or antiplatelet therapy. Many of our patients are taking this for various reasons, especially the low-dose aspirin, and antihypertensive therapy, seizure prophylaxis, and neurological consultation may be indicated. And seizures will be typically sometimes can be focal, neurological signs, can be prolonged coma, as I told you, can be atypical or recurrent convulsions, or they can even occur during and after delivery. Now, risk factors of eclampsia typically are preeclampsia gestational hypertension, Black and Hispanic race, advanced maternal age, but I also see very, very young teenagers also will have preeclampsia commonly, nulliparity, multifetal gestation, preterm delivery at less than 32 weeks of gestation, that is early onset preeclampsia, and definitely a substandard prenatal care. Now, several signs and symptoms may precede, and this is where a clinician has to be very, very astutely aware of this condition. Blurry vision, diplopia, scotomata, photopsia, transient cortical blindness, epigastric pain, severe persistent occipital or frontal headache. Please pay attention to these symptoms in all your pregnant mothers. They may not have hypertension, but they may still throw a convulsion. They may have HELLP. And the commonest symptoms that have been observed through few studies is 66% of them would have headache. So don't give her acidity medicines. Try to evaluate first why she's having headache. Visual disturbances, 27%. And epigastric pain is not always gastrocolitis or acidity. It may be stretch of the Gleason's capsule of the liver. So whenever we are looking at CNS, eclampsia, and critical care, we have to understand that eclampsia is the most common, easily identifiable complication occurring antepartum more commonly, 38 to 53%, intrapartum 18 to 36%, and postpartum 11 to 44%. Atypical eclampsia I have encountered about 3 or 4 in my lifetime, less than 20 weeks of gestation, they can occur, and convulsions may continue despite magnesium sulfate, which is our golden standard of treatment, and 48 hours postpartum, which is also called as postpartum eclampsia, may not essentially occur in women who have antecedent hypertensive disorder. It can be a de novo condition where we have to be aware. Seizures always should be treated promptly with intravenous magnesium sulfate. There is no need to go for diazepam or anything of that sort. Quickly deliver magnesium sulfate. Sometimes there may be resistant eclampsia, and you have to deliver supportive care such as recovery position, bite protection, supplemental oxygen is very, very essential. Now, sometimes you may have patients who have come with coma, and this can be typically seen in women with chronic hypertension. And today we are seeing that most of our patients of preeclampsia are actually chronic hypertension. And this is very important to understand because these chronic hypertensive patients will have very, very weak aneurysmal kind of vessels in their brain, especially the deep penetrating arteries of the lenticulocerebral branch of the middle cerebral artery, in the basal ganglia, putamen, thalamus, and such kind of areas, which are called as the Charcot-Bouchard aneurysms, and which can suddenly give way, rupture, cause hemorrhage. And therefore, any patient who has eclampsia or any kind of a CNS problem associated with pregnancy, always try to look for what is the cause. Now, the good news, however, is eclampsia may be considered a preventable disease in many of the cases. And this especially has been a huge game changer in the form of MAGPIE. And the trial got published in 2002 in the Lancet. I must confess here, Sneha and I have been residents in the BJ Medical College, Government College in Pune, Maharashtra. And we were there from the period of 1989 to 1992 doing residency. Before that, we were undergraduates together as well. And we were very diligently delivering magnesium sulfate. Some of our units used to give the Pritchard's regimen. And most of our units used to give the Zuspan regimen, and we were very happy and very experienced in giving this correctly. So this was Magpie trial, which came after that, and it showed a randomized trial was conducted in 1995, which demonstrated magnesium sulfate to be superior to diazepam and phenytoin. It was known to reduce the risk of recurrent seizures in eclamptic women by 52% when compared to diazepam, and by 67% when compared to phenytoin. And I know the Lytic cocktail used to be used when we were interns. And then in the little early part of our JR-ship, and later on we shifted to magnesium sulfate beautifully. And I think we were those first residents who really learned to deliver magnesium sulfate with a lot of confidence. And then it was also found that when they went and compared the effects of treatment of baby death for those randomized before birth and perinatal mortality rate, it was found that magnesium sulfate had better outcomes. So magnesium sulfate is an excellent medication which should be used with lot of confidence, and each one of us has to be confident because it is our medicine. Preventing seizures in women with severe preeclampsia, slowing or stopping premature level, and we know for neuroprotection, but also for treatment of eclampsia and for aborting a eclamptic convulsion as well. As I mentioned to you, inflammatory cytokines and immunological maladaptation is at the crux of the problem where preeclampsia occurs, and something changes where the patient is taken into the zone where she develops eclampsia. And therefore, we have to look at these very important objectives today: differentials, investigations, diagnosis, maternal fetal surveillance, emergency management, delivery decision, and conduct. Now, if you look at diagnosis, there has to be a strong clinical suspicion. It may be asymptomatic, it may be atypical, and early detection and prompt and appropriate treatment is the key for a successful outcome. Now, we all know the definition of preeclampsia, which is known to resolve 6 weeks post-delivery, and it is associated with hypertension and systemic involvement, and proteinuria being its hallmark. And eclampsia is characterized by onset of with preeclampsia. And you can see that this is something that I typically ask when I'm conducting this drill. What is amiss? This patient should be covered, be trained. There has to be respectful care. The positioning of the patient is not proper, and she can be at risk of developing aspiration, and we have to be taking care of this patient when they are throwing a seizure. Now, very important is immediately, it's very important to analyze the laboratory investigations, because there can be various grades of HLLP, various types of renal function derangements, and these have to be understood when you are treating the patient. And therefore, the moment a patient comes after you have given magnesium sulfate, it is very important that we are looking at the labs. Many of our patients who come to us with nothing else, but when you have done a sonography, especially at around 28 to 32 weeks, you will find that your sonologist or you yourself may come to identify that there is uteroplacental dysfunction or fetal growth restriction. Keep a watch on these patients. These are the ones who may develop hypertension as the time goes by. We have to remember at the problem and the quantum in our country. If you look at the National Eclampsia Registry statistics, it is found that 10.3% of patients would have preeclampsia out of the antenatal population, and nearly 2% of the pregnancies will be affected with eclampsia. This means that we have 26 million deliveries per year, and we are dealing with nearly 26 lakh cases of preeclampsia and 5 lakh cases of eclampsia yearly. And this is something which we have to remember as a very important responsibility that we have towards women's health. Because whenever you have this blood pressure coming up, you must remember that there are a lot of problems which are going to happen to the mother and the baby, and we are responsible. I mentioned to you about there being abnormal or shallow invasion of the spiral arterioles, and this context has to be always kept at the back of your minds whenever you are managing any kind of intervention, any fluids, any medications, and trying to assess how much is the damage which has been done. And we all know that all this starts from the time of the placental wave, which occurs at the outset, and it continues till about 16 weeks. So if at all you are going to give any interventions, they are going to be helpful if you start them at the outset. And that's the reason why we propose the justosis score, which can help you in identifying patients before the damage starts occurring, because placental ischemia is at the bottom of this, which gives rise to problems, giving rise to systemic inflammatory response like syndrome and endothelial damage, giving rise to systemic involvement. So in eclampsia, there is change in the neurosteroids, there is inflammation and infection kind of a thing, and there is disruption in the blood-brain barrier, and this has to be remembered. And this can have short-term and long-term consequences, such as white matter hyperintensities, ischemic and hemorrhagic stroke, cerebral small vessel disease, vascular dementia, vasospasm, and so many complications which can affect a wonderful brain structure, which is supposed to be one of the most tenacious organs that the human being is developed with. Now let's look at Ishani, who is a 32-year-old woman who presented on 4-day postpartum with hypertension and severe headache and was found to have severe preeclampsia. And look at it, what happened. She was subjected to identification of a MRI was done, and it showed that there was an intracerebral hemorrhage in a postpartum woman. And this can be only diagnosed by imaging, which can help us in upgrading her care. And in her brain biopsy showed no evidence of vascularity, and she was diagnosed with reversible cerebral vasoconstriction syndrome. Now, this is the best nursing care that you can offer to your patient. And you must also remember what is the gestational age at which the patient has got affected. If it has occurred before 34 weeks of gestation, then she is a mother who has the most complication rates. And therefore, you have to quickly identify whether there is systematic involvement and accordingly take care. And doing a justosis score, as I mentioned, will help us in identifying these issues much better. We have to look at these patients, and as you can see here now, this is a patient who has come for antenatal care, and she is complaining of not feeling well, got conceived with ovulation induction, and she had an uneventful course till 33 weeks. And you can see now what is happening.
Doctor, I had headaches since morning. Okay. Doctor, she's 8 months pregnant. She hasn't eaten anything since today. Okay. I'm also feeling nauseous and also had one episode of vomiting. Okay, just take her BP meds. Let me take your BP. Doctor, is it normal?
So you can see the blood pressure is being checked at 33 weeks in a sitting position.
Do you have
Immediately.
any history of raised BP earlier? No, doctor. Did you have any such symptoms earlier? No. It's 170 by 100. Okay, just lie down first.
So you can see that the BP has become.
Okay. Doctor, she's 8 months pregnant.
And 170 by 100, this patient, and immediately the doctor was very, very much on guard, and he said, please, because she's having so many symptoms, please take her down. Always remember that there are alerts in the patient, like any vomiting after in the second trimester, patients suddenly not feeling sick, rapid deterioration, and early diagnosis therefore is important. Typically, when they are telling you that there is epigastric pain, it can be the stretch of the Gleason's capsule. So likewise, this patient was typically taken and was made to lie down.
Okay.
The moment she was made to lie down, she threw a convulsion.
I'm not able to put it. Okay, just give her injection magnesium sulfate IM for now. Loading dose of magnesium sulfate can be given IM as 4 gram intramuscular dose.
So you can see here that if you are not able to deliver the magnesium sulfate intravenously, the patient is already convulsing. You can deliver a 4 grams of magnesium sulfate, taking 4 ampules of 1 gram, that is 50% each, and injecting it without dilution on her buttocks. Or if you have an access to an IV line, you can just put it in 100 ml of normal saline and deliver it, or give it through a syringe over 5 to 8 minutes. So immediately when there is a convulsion, always use this. Remember to take the patient in the right position. This is a code blue condition. Any seizures during pregnancy or any seizures for that matter, ask for help. And this is the typical nursing position of pregnant women with eclampsia. It has been found that magnesium sulfate is extremely effective, more than effective than diazepam and phenytoin, and it has an action where it blocks the NMDA receptors, reduces the presynaptic release of neurotransmitter glutamate, potentiates the adenosine action, improves mitochondrial calcium buffering, and blocks the calcium entry via voltage-gated channels. And also, it causes vasodilatation by relaxation of the smooth muscle. And this is something which many times people feel can be the reason why patients go into atonic PPH. But be on guard, it doesn't really associate itself with accordance of that alone. And generalized effect on the smooth muscle, including peripheral vasculature and uterus, has to be factored for. And magnesium is known to block the NMDA receptors in the brain, reducing calcium influx and protecting the neurons from damage. And that is the reason why it is a very important medicine. We should be absolutely well versed with the loading dose of 4 grams, which is given intravenously over 10 to 15 minutes if you are stepping it in the normal saline, or it can even be given over 5 to 8 minutes. And one has to be always ready with the magnesium sulfate box, and it has to be replenished regularly, because you saw anytime the patient can throw a convulsion. And these are the contents of the magnesium sulfate box with 50% ampules, intracat, sticking plaster. Make your own list, then ensure that the box is ready. And the moment a patient comes to you with a seizure, at 0 to 5 minutes, you should give her a lateral decubitus position, oxygen, and do suction, airway, IV access, avoid maternal injury, elevate and pad bed rails. Prevent recurrent convulsions by giving optimum dose of magnesium sulfate and continue with maintenance dose of 2 grams per hour as continuous solution, or 1 gram per hour also can be sufficient depending on the weight of the patient, and it can be given through a syringe pump. Control the severe hypertension. As we know, antihypertensive medicines should be given, and quickly take the labs. By 15 to 20 minutes, your lab should have gone to the laboratory. And then if she has a recurrent convulsion, you can consider giving a top-up of 2 grams of magnesium sulfate. Still she convulses, then you may consider giving her lorazepam 4 milligrams or levacepramide accordingly, and consider need for intubation. Prepare for delivery. Eclampsia is only stabilization. The treatment finally is delivering the patient. There is no role whatsoever for expectant management or postponement of delivery in eclampsia, and assess the need to transfer to a medical center with medical ICU and or neonatal ICU. Now, these are the typical dosages of antihypertensive medicines which are given, and we typically use labetalol or nifedipine. But here in a patient of eclampsia, when she's comatose, the best medicine antihypertensive is to give labetalol, and all of us should be well versed with the labetalol infusion. Remember a differential diagnosis. It can be epilepsy, syncope, stroke, hypoglycemia, cerebral malaria. And you should be always well versed with the checklist of hypertensive disorder in pregnancy, where you're going to give magnesium sulfate and antihypertensive medications. And if you see that the response is not adequate or the patient is complicated, you may consider stepping up the care to a better center.
Perfectly all right in the morning. Then she started having seizures. Then she went down and she's unconscious right now. Please help us.
So you can see that the first sentence that we said, that any convulsion during pregnancy is always a eclampsia, and it can be having several other things also, which we have to keep just at the back of the mind. But your first go-to medicine is always going to be magnesium sulfate, and this is how the eclampsia rules are. And wherein you can see that your patient is there, with the monitor, onto her head, and then she is nursed. So these are the dosages. The Pritchard's regimen is which the WHO recommends, because it feels that IV access would not be easily available. But if we have an access to IV, we should consider giving a Zuspans regimen, which can be very, very effectively delivered through a infusion pump or a syringe pump. And we all have to be well versed with this. Now remember, eclampsia is an hypertensive emergency, and therefore it is something that requires quick attention and treatment. Even if this particular chart is looking busy, you have to remember to follow call for assistance, designate a team leader, checklisting. There has to be a reader, a primary runner, ensure side rails, call OB consultant, document call, pace IV, Draw the lab, seizure prophylaxis, antihypertensive medicines, consider a urinary catheter, and brain imaging if there is excessive headache or neurological symptoms. We have already spoken about the antihypertensive medicines, which have to be taken typically. And we have to remember that one of the most simplest regimens, which I always feel, is the 20 milligrams IV regimen given every 10 minutes. And then after the second dose, if it's still not coming down, you can give 40 milligrams and continue till T20, 220 to 300 milligrams. So one should always be having these laboratory algorithms placed in your labor rooms so that in the emergency, you should not get unnecessarily flustered and all your team is aware as to how these medicines are delivered to the patient. Now, if the convulsions continue after 15 minutes, as I told you, we can give her magnesium sulfate and consider recurrent convulsions. You can consider other options for giving her infections, giving her antihypertensive medicines. Remember the therapeutic dosages and serum levels. Feeling of warmth, flushing, double vision, slurred speech is seen at 3.8 to 5.0. Loss of tender reflexes means the magnesium levels are more than 5.0. So keep a watch only on those tendon reflexes because the therapeutic range of magnesium sulfate is 2.0 to 4.0. And then if it goes a little more respiratory rate, if you're monitoring, then that will keep you always in a safety zone. But if it is depressed, then that means the magnesium sulfate levels have gone up. So the moment you have an absent patellar reflex, and if the respiration is normal, further dosage of magnesium sulfate can be withheld until the reflexes return. And if the respiration is depressed, then management to be as said earlier. Magnesium sulfate can be restarted if considered necessary once the reflexes have returned but at a reduced dose unless there have been further convulsions. Respiratory arrest, if there is happening, stop magnesium sulfate, give her 1 gram of calcium gluconate, 10%, 10 ml over 10 minutes with cardiac monitoring, intubate and ventilate immediately, and ventilation should be continued until the resumption of normal spontaneous respiration. If the patient's urine output is less than 100 ml in the 4 hours, if there are no other signs of magnesium toxicity, then you can consider the next IM dose of magnesium sulfate to be reduced to 2.5 grams or the IV infusion to the rate of 0.5 grams per hour, and particular attention to be paid to fluid balance and blood loss. Stop magnesium therapy if there is respiratory depression, give calcium gluconate, oxygen by mask, maintain airway and the recumbent position. Always remember that there are minor side effects with magnesium sulfate, and it's very important to be well versed as to how to interpret the laboratory investigations.
I'm having constant headaches since morning.
So you can see her, even at the time of discharge, patient can have this convulsion, and we have to understand how are we going to monitor the mothers. Very, very strict monitoring for the mother for her vitals and blood pressure. And the baby also has to be surveilled. Sometimes during the convulsion, there can be a deranged electronic fetal monitor stress. Don't get worried. It may recover back again. And whenever you are having any of these conditions, it's always better to quickly deliver this mother with proper optimization, especially in the presence of HELLP and in the presence of an abruption. You have to be very careful when you are delivering these patients. So once the patient has been stabilized, then we can consider delivering this patient. So after delivery, even if a patient of preeclampsia is planning to go home, be careful. She may still throw a convulsion. One of the most important successes to effectively manage eclampsia is by having a regular checklisting and ensuring that all your labor rooms are well-equipped rooms with oxygen, with maternal neonatal resuscitation facilities, eclampsia kit protocols and documentation. And also you can continue reporting to the National Eclampsia Registry. And thank you so much for giving me this opportunity. I hope I have been able to deliver. And this is a nurse in our facility who is doing the eclampsia checklisting, which should be your daily routine. Even if you have rare eclampsias occurring in your practice, always be guarded because one eclampsia can really, really create a havoc in your life and cause a lot of problems. Thank you for giving me this opportunity.
Thank you, ma'am.
That was such a nice lecture. I think you've covered in entirety everything. In entirety, we actually have at Neelafar Hospital, Hyderabad. We constantly have these eclampsia drills. That so that the assistant, the duty or doctor, the team, they do not miss the sequential management of everything with precision. And then the Juspan is an excellent way. We have switched to the infusion methodology, so that's an ideal way of giving the drug in the form that should be delivered in a critical care person. That IV infusion would be Juspan the ideal thing. Then about the dosages also of magnesium sulfate, if there were a elevated renal parameter, it should be realized, as you said, that the loading dose should not be stalled at all. Loading dose should be given, and then the follow-up should need to be maybe reconsidered about the dosages, the renal parameters are. And yes, looking into all the end organ damages, maybe we need to have a thorough understanding of all the effects on this elevated pressures on the cardiac system, because we always see when we do 2D echo for all the cases of eclampsia, we
Absolutely.
always find diastolic dysfunction.
Yes,
Grade 1 and 2. And one of the studies of 2024 February by Australian team of obstetricians, I was so surprised when I was going through the research gate. They say that all these hypertensive women, they already have a pre-existing cardiac disease that they have manifested as hypertension.
Yeah.
And that we consider it as preeclampsia. So that is also again a thing that maybe NCDs are so very rampant in the population that maybe the women are already, they are the byproducts of FGR of their mothers, that they've already, contacted the, early onset of all these disturbances in their physiology, that they are presenting as preeclampsia. And we have really seen rise of preeclampsias and hypertensive disorders of pregnancy. That's an excellent and fantastic rendition. I tell you, that was so very elaborative and then thought-provoking as well, Girija. Nice.
Thank you,
I'm
Dr.
very
Anita. I must congratulate you for bringing the cardiogenic issue into this
Yes.
discussion, because this is something which is not really taken very seriously, because
Yeah.
as we were trainees, we were always looking at younger mothers, but today
Yes.
we have older mothers, they're obese, they have so many other issues. Secondly, we have done a study in our institution where we did HS troponin I for screening and for risk stratification of these mothers. And we found that it was significantly high, especially in women who had severe preeclampsia and hypertensive disorder. So it is a cardiac malady, definitely. And that's the reason why syringe pump magnesium sulfate is mandatory, because it will help infusions, fluid restrictions,
Yes.
and everything will be properly
Yeah,
monitored.
true.
Your hands free to do it. So, you can deliver the drug very, very well. You are not depending on somebody to calculate the dose and forget the dose. And I can see that Sneha and Parag will be smiling inside their minds about this, because at Sassoon we have had these challenges sometimes. 25% given instead of 50%, and 50% given, and what not kind of challenges would occur when magnesium sulfate used to be given.
Yeah, right, true.
Thank you, ma'am. Wonderful deliberation. Actually, it is all in all for the postgraduates, interns, consultants, and nice inputs by Dr. Anita, our professor and HOD from Nilofer. So still, I would just share one case where, it is actually my niece, the case that I'm sharing. Totally, though it was an IVF pregnancy, totally, she went through the whole pregnancy very uneventfully. Absolutely no hypertension, no diabetes, no nothing else, no BMI, high BMI or anything. So LSES was done for a fetal distress, and she went home on 5th POD. On 6th POD, I get a call that it is throbbing headache, very severe throbbing headache, and they were about to give some paracetamol and all. They said first check for the BP. They had a digital blood pressure apparatus. It was 200 by 100. And then to get that girl from the town to the Hyderabad, the magnesium sulfate was not there in PHC, the whole dose. It was there, but the expiry was done in some of the hospitals. Then finally, we could get 4 ampules in an ambulance, 108 ambulance. Then that was given, and in transit, another the full dose of magnesium sulfate was given. But after admission, it turned out that it was not simple, postpartum eclampsia or preeclampsia kind of thing. She continuously went on having high fluctuations of blood pressure throughout her 1 week of postpartum stay. So it was atypical in the sense it came on 5th POD, 5th or 6th POD. Then she was admitted. Then she was brought into the room, ready for discharge. Then again her blood pressure and her headache would shoot up to 200, 170, 100. everything was done. 2D echo was done, ECG was done, then MRV was done, which are all were normal, ma'am. But she needed 2 antihypertensives. And then it started like they did, we had to do the chromogranin, neurologist opinion, chromogranin was done. Actually, it was high chromogranin. Still, she's waiting. She has given her vanillyl mandelic acid sample 24 hours, waiting for the report. But luckily, it has stabilized and she's weaned off 1 antihypertensive. The second one dose is reduced. But still, I'm scared. She asked, can I go to the town? I still am scared to, send her to the town. This presented so difficulty.
Let her finish
I saw the difficulties of getting magnesium sulfate, giving it, bringing her. So atypical features is one thing that we have to be really
Kiran, you have been very lucky with your knees. I have lost a patient on the 5th POD.
Yes, ma'am. I mean, I was one whole week. It was like, but I was always discouraging discharge. Even when they were saying we can discharge, she's stable. I said, stay this one night, stay this one night. But as I expected, she would have that. It was very typical, that headache and blood pressure. Now it seems like.
So thank you so much, Girija, for that wonderful, excellent, and very informative talk. I would say it's not only informative, very practical, much needed. I'm sure people who are even today scared of using magnesium sulfate also when to use, how to use, and of course, all the things what you have demonstrated with actually the role plays and all the videos. I'm sure it has been very helpful. So thank you, chairpersons also. And of course, Girija, my dear friend, my batchmate. So it's always a pleasure to have her as a speaker. She is the master of this subject. And I have another friend who has just joined, Dr. Parag Piniwale, who is the Amogs national coordinator. I think this sound okay. So
don't waste
I will not waste any time. Yes, the ICU chairperson.
I'm a co-opted member of OGHS anyway. It's wonderful to be back virtually with my Hyderabad girls, and thank you very much for the invite. I bring greetings from Amogs as a national coordinator. Sneha, we are really proud of you as Amoxians because you are reaching out to other states and there's an excellent exchange of knowledge. Girija, you were wonderful as usual. And when 3 of us were junior residents in Sassoon, I mean, what Girija described just now used to be a day-to-day affair, and all of us really struggled at that time. Of course, Maxself, as Girija said, was very, very new, but then we were really lucky that we used only Maxself rather than any other regimes. I'm not going to take much time. My best wishes to you, Sneha, for your forthcoming elections, and Kiran, please convey my best wishes to Aruna. I can't see her for her elections as well. Thank you very much. Yes, thank you very much. And let's go ahead with the program.
Thank you so much, Parag. And we know.
Sneha, I think I need to be excused.
Yes,
I would
definitely. No problem. So I think I will introduce the panelists. Of course, it will be my pleasure to introduce. Saiti, can you project their slides, please? So Dr. Sarada Mamila, who is the consultant obstetrician and gynecologist from Yashoda Hospital, Samajgoda. So we welcome you, Dr. Sarada.
Thank you. Thank you, madam. Thank you.
Yeah, pleasure. Dr. Santi Sri Asuri, who is also a senior consultant of gynae DNB coordinator at Fernandez Hospital, Hyderabad. So we welcome you, Dr. Santi, and Dr. Archana Singh, our dear friend, who is the past secretary of OGSH, and of course, she has lots of credentials to her credit. Definitely, we're going to have wonderful interaction. Welcome, Dr. Archana. And Dr. Anita Sidhu. Dr. Anita, I hope you got it corrected. I think your voice is still not, I think we could hear you just now. That was good. We'll be very happy to have interactions from you. Dr. Anita Sidhu, who is the professor, Nilofer Hospital, Hyderabad, teacher, guide, mentor, national and Lancet publications, and she's got so many guest lectures and so many TOT, NRP, RBSK, and she's worked in NIN and ICMR, and of course she has received the Best Doctor Award twice, so that is great. Hearty congratulations to you, Dr. Anita. Welcome. And Dr. Goli Mahalakshmi. She's also a very senior consultant of Gynae, and professor and unit head Department of Obs Gynae, Gandhi Medical College, Hyderabad. And madam has lots of awards and accolades, publications to her credit. We are very happy to have you, Dr. Mahalakshmi. Welcome. Dr. VP Josna, I think could not be joined. That is what she has conveyed. So with this brief introduction, I'm happy to have all of you. And without much ado, we go ahead with the panel discussion. I hope you can see my presentation.
Yes, madam.
Yes, ma'am, they can see.
Yes. So I just take this forward that, I have already welcomed all of you. I would just ask you that when do you label the hypertension as severe hypertension? Because nowadays you have only two categories. One is severe and the other is non-severe, as against what we had mild, moderate, and severe previously. So can we start from Dr. Sarada?
The hypertension, the systolic blood pressure is more than 160, the diastolic blood pressure more than 110. We say it's a severe hypertension.
Yes. Any other criteria you include apart from blood pressure?
With any organ.
Significance of it?
Yeah, with hypertension with any end organ dysfunction, be it proteinuria or any fetal damage or any other things, we call it a severe.
Yeah, but then how does she present clinically? How do you recognize?
Clinically, she'll present with any symptoms, lot of headache, blurring of vision, any epigastric pain, nausea, vomiting.
Right. So definitely a very severe headache, blurring of vision, upper abdominal pain, and then severe pain, maybe, decreasing urine output, and also maybe other complications like, HELP syndrome and all. Maybe you have some little jaundice you can make out clinically. So all these are the all these can be the symptoms also of severe hypertension when you, as rightly said, that yes, 160, 110. If it is more than that with the associated alarming symptoms and signs, you label this as severe hypertension. Now, what is the importance of this? As you said rightly, that she can have, very severe headache, blurring of vision, breathlessness, vomiting, upper abdominal pain, reduced quantity of urine. So all these can be the symptoms. So what is the significance of this? Why are we worried about this severe hypertension? Yes, Dr. Sarada, continue with this.
So these symptoms, they suggest severe hypertension will have their complications. So as Dr. Girija has already discussed, the eclampsia is one of it, and we can have other complications. It can be HELP syndrome, can have retinopathies, and renal failures, or she can have pulmonary edema, cardiac complications, intracranial hemorrhage. So we are worried of the complications with the increased hypertension.
Right. As you have rightly said, we are worried about, first and foremost, we are worried about this very high blood pressure because our vasculature is not adapted to such a high blood pressure, and the vessels can give way. So hemorrhage anywhere in the body, that's a main reason. And then, as you have rightly pointed out, all these complications. In addition to this, as you said, the liver hematoma, subcapsular hematoma, the hepatic rupture, and all the complications, whatever you have said, definitely, these are worried, and that is why you are supposed to manage this hypertension within 15 minutes. You should not allow this. You should not allow this blood pressure to remain there for more than 15 minutes to cause its adverse effects. So as you have already talked about, most important, I said, the hemorrhage, and that's a very reason: abruptio placentae, subcapsular hemorrhage, intracranial hemorrhage, and then you have other acute kidney injury or acute tubular necrosis, And ARDS and retinal detachment, all these are the complications, though myocardial infarctions and pericardium cardiomyopathy can also be the complications from the same, right? So our aim should be to act faster and avoid all these complications. So with this intention, now we go ahead with the case-based discussion. So Dr. VP Josna, we don't have, but we can have Dr. Anita. We're very happy to have you, Anita. And we have this 36-year-old lady who conceived on IUI. Her husband stays in Dubai and she stays in a village. But because this is a precious pregnancy, she comes to you for regular checkup, comes to her regular obstetrician for regular checkup. So she is told that everything is fine at 28 weeks. Suddenly she goes to the PHC, and at PHC at around 34 weeks, she comes with the blood pressure. She comes as pedal edema, with the complaints of pedal edema. When they examine at PHC, the blood pressure is 178 by 118 or 116 millimeter. Okay. So what is the diagnosis at this point of time, and what are the investigations we should do? What would be the management according to you?
Yeah, the record by itself, we are fortunate that at least at PHC, a proper BP recording is being done in our country. So with at least the record is suggestive by definition that she is in a severe pre-eclampsia case, and her gestation is at 34 weeks. At least we are happy that she reached 34 weeks with that record. Right. So that way at least we can have an early decision making and early management in terms of conducting delivery also, because that is a mainstay of managing eclampsia.
Right.
Because we want to prevent eclampsia in this case. The early that we diagnose, handle her blood pressure, and then give her some treatment to avoid seizures. That was the best way. But right away, the investigation that we should be offering is first and foremost, the counsel the patient, counsel the team, the significance of this record and the end organ dysfunctions and the condition of maternal morbidity or the extent of the high risk conditions of mortality also. And without wasting much of time, she should in fact be tagged to the higher center with a proper antihypertensive dose being given. In all our PHCs, even if labetalol is not available or an injectable form, nifedipine is supplied to all the PHCs. So nifedipine will be the mainstay for with any ANM or anybody who has recorded the blood pressure. Even if the medical officer is not given, our high risk pregnancy protocol that we have developed through Arman team, we said even at the peripheries, if the BPs are high, ANM is entitled even at subcenter to give a antihypertensive.
I would like to interrupt you here just to acknowledge that the points you have brought out are very, very important. First and foremost, that they could diagnose that this is a very high blood pressure. And second, as you rightly said, that capsule nifedipine 10 mg, the orange color capsule, that is the one. They should give it at once orally, not sublingually, sublingually. That is at least that minimum training they should be given. They should be offered. Secondly, as you rightly pointed out, this discussion is only to sum up what you have said, that she has to be referred to the higher center, because at this point of time, she needs the higher investigations, the detailed investigations, and she needs a very specific management. For that, she needs to be, referred to the higher centers. So unfortunately, this patient was not referred to she was advised admission, but she refused straightway. So naturally, all these things were not available there. So unfortunately, these medical officers did not have any knowledge. They started her on tablet nifedipine retard. Okay. So that's the very reason the blood pressure remained in the same range. Now, after 2 days, she got, admitted at a higher center, and that was the sub-district hospital. But before this, is there any role when she is having, upper abdominal pain and all this thing? Is there any role of magnesium sulfate? And is it allowed, or rather, is it a tradition to give the initial dose of magnesium sulfate even at PHC?
Yes, there are two schools of thought even on magnesium sulfate again.
Yes.
So severe pre-eclampsia cases also, when there is an impending doom, as it is realistic about the records that are seen, always magnesium sulfate will play a better role with when a loading dose is being given. If not a continuing of the dose as a continuing of the dose cannot be practiced, at least the loading dose will definitely be helpful to be practiced.
Yeah, very good. We acknowledge your message that at least the initial dose of magnesium sulfate should be given at PHC, because that can help her minimize the complication. At least at every convulsion, the amount of cerebral edema she will have, and that will further raise her ICT, and that will further make her convulse, will definitely can be prevented by the initial or the loading dose of magnesium sulfate. So, but unfortunately, this patient was not given magnesium sulfate. She was started with tablet nifedipine retard 1 pg. And then when she was shifted to the sub-district hospital, she was given only tablet labetalol 200 milligram twice a day. So, the things have not worked well for her. And that is why when she was referred to the tertiary care center, even on admission with these two drugs, blood pressure was 170, 112, that is, the same. So should we label this as a refractory hypertension?
Actually, the right dose of antihypertensives are not delivered
been given.
That is what we want to say. The message is here that she has not received the proper drug, the proper dosage. So we do not call this as refractory hypertension. Now, where to hospitalize such patient? Because you can see she came from PHC in the higher center. That means she got admitted to SDH, sub-district hospital. So what is your take on this? She's to be...
Yeah, she needs... See, it's always commutation is a problem. Let us be realistic. Commutation is a problem for the women if they are coming from some of the interiors of this country. So the nearest district hospital, all the district hospitals under NHM are equipped to handle all the cases of such magnitude. And it is, that a revolutionary approach. It's a basic mandatory approaches that should be meant for all the cases of hypertensive disorders which are in severity range reaching the district hospital. So the district hospital, we have anesthetists posted, we have an obstetrician, we have surgeons. In fact, some hospitals are equipped with maternal intensive care services along with
So even the district hospital is very well equipped with all facilities, right? That is what we wanted to, make everybody aware of. And now, how do we control this hypertension? I think we can pass on this question to Dr. Shanti. Dr. Shanti, do we have Dr. Shanti? Yes,
yeah.
please.
Good evening, ma'am. Thank you for the opportunity.
Put on your video, plus we'll be happy to see. Yeah.
Right. Sure.
Yeah.
So ideally, whenever the mother comes with severe hypertension, she needs a referral to a tertiary hospital. That is an idealistic situation. But at least she needs to be treated with the appropriate dosage of medication. We cannot give her suboptimal medications and then keep her life at risk. So whenever
in other words, I would like to interrupt you. In other words, for severe hypertension, we do have definite management, right? As Dr. Nita said, oral capsule leptin is one. And what are the other drugs?
Yes, if at all it is not getting controlled, if at all, first of all, if the lady has an IV access, IV labetalol is the first drug of choice for the management of acute severe hypertension. If there is no IV line, or if someone cannot give IV labetalol, then capsule leptin orally is the first drug of choice. And it should never be given sublingually. Okay, and as we do give her medications, we can give IV labetalol initially to start with 20 milligrams, followed by 40 milligrams, followed by 80 milligrams, and we should not exceed a dosage of more than 300 milligrams. If it is not getting controlled with IV labetalol, then we have to think of hydralazine as a second line of drug, or we can add nitroglycerin if at all, if we have an ICU, intensive care unit setup. But ideally, most of the times, it so happens that with IV labetalol and IV hydralazine, it gets controlled.
Right. So now you have this patient with severe hypertension and with alarming symptoms and signs. Your first and foremost aim was to avoid convulsions, so you have given her magnesium sulfate full loading dose. And now you have given her a very effective antihypertensives, maybe IV labetalol or oral nifedipine as per the availability and the comfort of your use as well, right? So you all are monitoring this patient.
Yes,
Now,
ma'am.
how do you plan the management ahead? Because whether this is a hypertensive emergency or urgency, how do you decide that? Whether we can
Right,
take
we
this
decide based, right, whenever when there is preeclampsia with severe features, when the BP is more than 160, 110, it could be either a hypertensive emergency or urgency. The difference between the two is presence of end organ damage. If there is end organ damage, we call it as hypertensive emergency. If there is no end organ damage, then we call it as an urgency. Urgency gives us some time to control the BP, whereas in an emergency, we should be very quick in acting to control the pressures so that there are no further sequelae for the mother. Apart from that, we have to stabilize the mother, get the investigations done, and prepare for her delivery, because the treatment for preeclampsia is delivery. So with this, we have to do only after maternal stabilization.
Now again the same question remains: what all investigations you want to do for this patient to decide whether it is urgency or emergency?
We should
Right,
be sending
we do
her.
a battery of, yeah, sorry, sir. Please carry.
Yes, Shanti.
Right, we can actually individualize the case, and then we can get a battery of investigations for the maternal and the fetal evaluation. Maternal evaluation, ideally we do a hemogram, we do a complete urine examination, urine protein creatinine ratio, serum creatinine, we do the liver function test, renal function test, serum creat and uric acid already, and then we do a coagulation profile in cases of high PE with severe features to rule out any coagulation abnormalities.
Suppose you find that there is evidence of end organ damage, how do you tackle this patient? And suppose you find that there is no end organ damage, then and what about the magnesium sulfate? Because you have already given a magnesium sulfate.
Magnesium sulfate is the first drug of choice to prevent eclampsia, and it is a very safe medication. The numbers needed to treat would be about 71 mothers. We have to give magnesium sulfate to prevent one case of eclampsia. We give magnesium sulfate if there is no urgency, if there is an emergency, we need to stabilize the mother and deliver the baby. If there is an urgency, probably we can wait for the fetal lung maturity and then again stabilize the mother and deliver her. Urgency gives us some time, but emergency does not give us much time.
Right. So if you have end organ damage, naturally you have to look for, the ways to go for deliveries. You have already given a magnesium sulfate, maybe, but she's already 34 weeks. So this is not for neuroprotection. This was for the mother to avoid eclampsia, right? Anything else you want to give to this fetus to prepare?
We can give antenatal corticosteroids, because RCOG recommends giving steroids up to 34 plus 6 weeks of gestational age.
Yes.
If it is not an emergency, we can wait for the effect of the steroids and birth this mother.
Just to complete the discussion, which steroid and how much?
Betamethasone / dexamethasone. The government of India recommends dexamethasone, but we, for the sake of convenience, we are giving betamethasone 12 milligrams, 2 doses, 24 hours apart.
Okay, so you are not using dexamethasone?
In our institute, we are using betamethasone now.
Okay, even majority of the times we private practitioner also were using a betamethasone previously, but the fact is that the betamethasone salt which is used in the Western countries, which is studied and found to be effective, was propionate or acetate, which is not available in India. The salt which is found to be effective is not the one which we get in India, and that's a very reason I think we have shifted over to dexamethasone.
Dexamethasone.
Yeah, so this is what the message I have already delivered, but I want to again say that, never ever sublingual dipping. We may lose the patient also, and because of sudden lowering in blood pressure, we may lose the fetus also, right? The fetus is adapted to this circulation and high blood pressure. So is there any role of magnesium sulfate that we have already covered? This patient wanted her husband to come from Dubai, but naturally we also wanted at least 24 to 48 hours of time for the, but then this counseling and explaining the maternal and fetal complications, everything was done. So nifedipine and magnesium sulfate, that all of this is only to remember the points. Now, this is what I'm trying to sum up, that yes, people do have, in so many webinars, they ask me, can you give capsule nifedipine when the patient has already received magnesium sulfate? Magnesium sulfate is not at all antihypertensive, though it has got some blood pressure lowering effect through the central mechanism. You can definitely give magnesium sulfate with nifedipine, and magnesium sulfate is to prevent convulsions. Okay, we never use eptoin as the physicians use it. So close monitoring is very, very advisable. All of you know about this. This all we have discussed. So suppose we have to take this, Dr. Archana. Now this is for you. Suppose we have to take this patient for cesarean section. How do you prepare this patient for cesarean section as far as the IV lines, the preload? If you want to say some, a word of caution for preload, yes, please go
As
ahead.
Dr. Shanti has already told about the importance of blood investigation, I just want to add, in these cases, it is always better to have ECG and 2D echo also for the mother, beside having fundoscopy and all, and complete blood picture, LFT,
Yeah,
RFT.
just to make the point that Tamil Nadu government has taken this as a routine for every pregnant woman, and they're doing at the beginning, I mean, early part of the pregnancy, and they're doing it just before the delivery also. But I think at least in third trimester, when you have the maximum stress, we should have, especially those, because it's a low resource country. So we have to do it at least for the high risk women, and this is the one who definitely needs it. Go ahead, please, Archana.
Yeah, then coming to preload also, we are always having the biased idea that we have to see that patient is well hydrated in labor. But this is the condition we have to see that she is not overloaded, because overload is going to cause complications. So not more than 60 to 80 ml or 1 ml per kg body weight per hour we can have, but we have to be very careful. Overload should not be there. So then third is that yes, we have to be ready with PPS, so we should have all the this thing ready, because in armamentarium we are not using methergine injection because she is already a PIH case. So all other methods should be ready for it, and thus we have
what
to
is your choice of oxytocin? I will
yeah,
still
oxytocin we have to give in a post, I mean, after delivery, say 20 units we are giving, but only thing we have to see that it is how is the renal output, how is the renal function, because sometimes these things may, if we are not missing them, then these patients may go for pulmonary edema also.
Okay, I would just interrupt you here. What is your opinion on carbetocin? Can any other panelist would like to add on the carbetocin?
We are using them.
Yes.
We are using, and it is giving good result, ma'am.
Yes, because I am using this as a routine.
And it is
We are using carbetocin, we are using for all women, actually.
Yes, that is
And
what
it's
I'm
because
saying. That has reduced the further need for other oxytocics, right?
Yes.
Irrespective of the brand name, we are making this statement out of our personal experience that, carbetocin is very, very effective. And of course, the pharmacokinetics also supports it very well. That, if you give it one single shot of carbetocin, only 100 microgram, that is equivalent to oxytocin infusion for 16 hours. Okay, so that effective is this only if it is given as a prophylaxis. Once you give oxytocin, whether it is for induction, augmentation, or as a treatment for PPH, carbetocin doesn't act, because the receptors, once they get they're depleted, carbetocin doesn't act that effectively, and that's a very reason we should give it as a prophylaxis. Correct? Yes. Okay, go ahead, please, Archana.
And then we have to be ready with
about anesthesia. I want to have your opinion.
In most of the cases, we still give regional anesthesia, but in certain cases, general anesthesia will be needed, and we have to see that the risk assessment and information to the patient is done before giving general anesthesia, because sometimes if we are changing the mode of action, mode of planned way, maybe we had planned a regional anesthesia and we are converting to general anesthesia, we have to always inform the patient and her attendant, because intubation itself may aggravate the symptoms. Then comes we have to be very careful in post-operative, not only monitoring her renal function and liver function, but also infection, which is one of the cause of getting patients into renal failure and getting into complications. So these are the things we have to be very particular.
And of course, 34 weeks baby with such high
neonatal care should be there.
Neonatal care. So everything has to be taken care. So you have discussed this aspect very well. Do we have Dr. Mahalakshmi here? Dr. Mahalakshmi? I can see some of the faculties as panelists. Can we know, can somebody make a call to the faculty? Sahiti, can you see who is there, who has joined?
I think Dr. Mahalakshmi has not joined.
Okay, I can see 2 faculties as doctors. That's the reason I'm asking. So maybe we go ahead with the discussion. Once again, the same round. That now this patient, no, she underwent cesarean section, 1.9 kg baby delivered, female child. Blood pressure, even after all this, because the treatment she received, all of you know, this is what we are discussing. Ideally, it should be like this. But she received tablet nifedipine retard, tablet labetalol 200 mg/bt, and of course antibiotics and all this routine preload. About 24 hours later, suddenly she started developing breathlessness, restlessness. Her blood pressure is 200/118 and pulse rate is 115. Saturation goes down to 75%. Her chest is full of wheeze. Now what is this happen and how do you treat this? Dr. Mahalakshmi, that was for, but we can start from Dr. Sarada and Anita.
Yes, madam. So this is clear case of overload. So she's been overloaded with IV fluids and she's landed up in pulmonary edema.
Do we call this as overload purely, or it is pure pulmonary edema, maybe by whatever reasons, which we have contributed by overloading, right?
Yes.
Severe
and we did not control the blood pressure properly. Without
Yes.
controlling the blood pressure, we have given her IV fluids and
yeah. So
this has contributed to this.
Agreed. How do you manage this now?
So again, we have to pulmonary edema. We have to decrease the overload on it. Give her Lasix infusion so that
it's a crisis, right? It's a very
crisis. Yes.
situation. So you
we have to involve or shout for help. We have to involve the intensivist, anesthetist, and the emergency people, whomever we can take help from, and take care of her airway, breathing, circulation, ABC basically. So she's overloaded. Her lungs are loaded with fluid. We try to remove the fluid from the lungs, give her oxygen, control her blood pressures. And labetalol, no, madam.
Yes, tell me, what is your view on labetalol? Because even I have this is a ready-made presentation, but I can talk about this, that even I have the some difference of opinion here for labetalol.
Yes.
Yeah, say that.
Actually, pulmonary edema as such is one of a significant adverse situation in severe eclampsia. So
because this is a standard presentation of justosis. I have not edited this. Okay, so when you have failure, cardiac failure, when you have asthma, when you have severe bradycardia, these are the 3 contraindications for labetalol.
Labetalol should not be used here.
Yeah. Okay. Yeah.
Plus Lasix, ma'am, we can use more.
48.
20 mg. I mean, we can give up to 40 and sometimes 60 also may be given.
I'm saying 80 milligram. I'm saying 80 milligram. That is what we have been, because we know high risk
we can give to
yes.
save the patient, ma'am.
Yes. So in fact, initial dosage is 80 milligram. We want this patient to come out fast.
Yes, come out of it.
Because she is overhydrated.
Yeah, there is hesitancy about giving furosemide. Absolutely, that should not be there.
I always say stop giving pediatric dosage of furosemide.
Yes.
Okay,
Yes.
so that is
Yes,
what is the message
Yes.
for our women, our obstetrician, that use
yes.
initial 80 milligram because she is in
Yes.
overload. She's not going to be dehydrated or in negative balance. Okay.
She
In fact,
needs
salix.
oxygen. She
Yes.
needs oxygen. She needs propped up position. She needs Lasix immediately.
Right.
And she needs absolute control of blood pressure and evaluation of cardiac system. If she's got a cardiac failure in terms of PPCM as well, because her heart rate should be controlled, her respiratory rate should be analyzed. And if it's going on, maybe if it's going to be a PPSM with the ejection fraction lowered, the other drugs also will come into play, because the other drugs should come into play
Yes.
to have an effective
So
cardiac.
I would, yes. So I would just ask you, Dr. Anita, that when you are doing this initial management, it's only the
Yes.
immediate management, first aid for this.
Yes.
And by the time you are sending all the investigations of getting done all the bedside investigation,
Yes.
make
Yes.
sure that it is pulmonary edema and not
Edema.
something else. So what are all the investigations we should be doing?
See, apart from the
Routine.
Apart from the routine, yes, we draw samples for ABG as well, and we also send for in the sense electrolytes, and we send for the team is involved for cardiac function also, X-ray chest as well, because after surgery, that if the woman comes into this scenario, we should have other things also in mind, because we do not know there is a level of sepsis in her as well. We do not know. It's a referral case as well. So we always look for repeat of all the investigations.
Right.
Add on the specialty investigation in terms of echo and X-ray chest, ABG as well. And the immediate report from these will help us analyze the situation. And if we are not having these things to understand, at least the early warning signs are suggestive of something, and a blood picture in terms of hemogram where you see an NLR ratio, altered NLR ratio, or a blood picture which is suggestive of raised ratios compared to the earlier, or a raised altered electrolyte levels and urine output, they all mean something, because even in a dysfunction, urine output drastically comes down. If we keep measuring every our urine output, you will also know there is dysfunction is going on. So we have to be very, very vigilant about all the end organ parameters actually.
Yes. You have said it all. Only I would just add one, including infection we have enlisted here. Thyroid storm can be, undiagnosed thyroid.
Yes. Yes.
One of the complications that can lead to sudden pulmonary edema. And then, of course, this patient was on, 70%. This saturation was 70%. That is what I have said. This patient was managed. The anesthetist was called for. Everybody was called for help. So immediately she was managed by the anesthetist. But this patient landed up into cardiorespiratory arrest. Then she was intubated, put on mechanical ventilation, and then after 1 hour of all this management, things got settled. I would like to introspect ourselves or retrospect that whether we could have prevented this complication and what went wrong all the time, right from the beginning. If you go to the history of this patient, what things went wrong. And with this, we will conclude this first question. What things have gone wrong? Dr. Shanti, I think you can take up this question, whether we could have prevented this.
Yes.
We have covered all the points. This is the last point which I am asking, whether we could have prevented. I would say rather predicted and prevented. Dr. Shanti, do we have Dr. Shanti here?
Yes, ma'am. I'm here. Right.
Yes.
Initially, first of all, we should have controlled her hypertension in a better way when she presented to us.
If you don't mind, I will just guide you that, right from her history, if you feel that, 36-year-old lady who conceived with IUI, so all those maternal characteristics, if you think of,
yes, we could have, going by the inverted pyramid of care, what we could have done is initially, we could have done the double marker, placental growth factor screening and uterine artery Doppler and put her on echo spring so that her risk of developing hypertension would have come down, and monitoring her blood pressures on a twice weekly basis or a weekly basis would have helped us in picking up hypertension early. Once she has come to the hospital, with severe hypertension, with severe features with imminent eclampsia. That is, she has come with the heartburn also. So in that case, we should have started her on Maxelt immediately and controlled her hypertension better with IV labetalol and managed her. Then and post-operative, right from there to delivery to post-operative period, judicious use of fluids and appropriate post-operative care using an early warning chart would have averted this dangerous situation for this mother.
Dr. Sneha, you're muted.
Okay, sorry. So you have said it all. I would just add to this discussion that the maternal characteristics is one point, So you can score it as SDP justosis score, and if the score is 3+, in addition to what you have said, you have to triage this woman at 11 to 13 weeks by the inverted care of pyramid, as you rightly said. That if the score is high, that is more than 3, you can start her on low dose aspirin and high dose calcium, that is 1.5 to 2 gram of calcium. So it's not that you can prevent the hypertension, but you can at least keep a watch on it and you can try to optimize the outcome, right? Try to prevent the complications. So that is what is the most important point. And then, of course, as you said, she was managed very badly. The antihypertensives were not given according to the recommendations. Right. So thank you so much, Dr. Shanti. Now we go ahead with the second case. Here we have 31-year third gravida, para 1 L1 with 2 spontaneous abortions. I think that should come gravida 4. 34 weeks gestation seen in the antenatal clinic with complaints of vomiting. Blood pressure is 130/90. She has no proteinuria. Hemoglobin is 8.5 gram%. Platelet is 70,000. SGPT 60. SGPT 76. LDH is more than 600. Very classical case I have given you. What is the probable diagnosis? How will you manage this? Can you prevent this? And how do you manage this? I mean, you can take this discussion ahead, Dr. Sharada.
Yes, madam. So this, with this elevated liver enzymes, low platelets, picture of hemolysis, we definitely see that the HELLP syndrome is developing in this lady.
Okay. But then elevated liver enzymes, how do you define or how do you label? Normally also, as all of you know, that the liver enzymes are elevated during pregnancy. So at what level?
More than 2 times the normal of the lab reference values, more than 2 times.
Correct.
We call that as a HELLP syndrome.
Right. So this, as you have rightly said, this is a very classical picture of elevated liver hemolysis, elevated liver enzymes. LDH is also very high, low platelet count, etc. So it is HELLP. So how do you manage this? These are the different clinical features of this, and that I would just say that from my practical experience and what we have come, even the justosis says that if we have a pregnant lady with persistent vomiting beyond first trimester, if you have a lady with persistent vomiting beyond first trimester, continuing during second and third trimester, think of HELLP. Okay, she is the one who is going to land up in HELLP. That is what is the observation, you can say that. And this is what is the evidence also that this patient, actually they have 45 to 80% patients, they have nausea, 50% of them have persistent headache, they have almost 80 to 90% of they have malaise and increased blood pressure, proteinuria in 85 to 90%, and edema. Okay, so what differential diagnosis would you entertain in such clinical scenario? If not HELLP, what else it can be?
So this lady had elevated liver enzymes, so we can think of any liver conditions,
like
any hepatitis.
Like acute fatty liver also,
hepatitis.
but here hypertension is there. So
acute fatty liver of pregnancy. And
this case, which has a history of 2 abortions also, she could be having other thrombotic conditions. We should carry the suspicion that she could be a woman of thrombotic microangiopathies also, because that is also very common. In fact, we are the raise of detection or whatever be the reason, we are seeing so many cases of TMAs as well.
Yeah.
So I think
even TTP, thrombotic thrombocytopenic.
Yeah, that includes 3 things.
Yeah.
TMA includes 3 things. We have either TTP or you have HUS. some such scenarios, or catastrophic APS, CAPS. It could be CAPS as well. So we do not know where we land unless we it.
Right. What is the very classical feature of acute fatty liver of pregnancy? Whether how fast and how severely the enzymes are elevated? Is there any classical feature of AFLP?
Actually, we have the Swansea criteria, but however, if it's a profound hypoglycemia, we generally feel like suspecting. But again, we have to understand that acute fatty livers are rare as compared to sepsis. If the severe sepsis is down of liver function, that can as well present with hypoglycemia. The initial sepsis, you will have hyperglycemia. But if the liver function is further deteriorates, it's hypoglycemia. So I think if you have high index of suspicion towards sepsis, rule out sepsis, then we can land on AFLP.
Right. So, any specific treatment for HELP? First and foremost, I would ask you whether can you prevent HELP? And second question is, Dr. Anita, this will continue with you. We'll be happy to listen to you. Whether you can prevent HELP syndrome, any preventive measures, and whether there is any specific treatment.
Prevention, actually, the interplay of many things, the role of steroids, and how the handling of the class of HELP. Actually, the class of HELP, there is as such no prevention.
That is what, because through support happen in non-hypertensive women.
Non-hypertensives, yes, absolutely.
So it's not that if you prevent hypertension or if you treat hypertension effectively, you will prevent her from having HELP. Okay, 10% of these cases, they happen to non-hypertensive women.
Yes.
So that's one. And is there any specific treatment? People have said that, yes, IV steroids. So what is your take on this?
Actually, the latest textbooks also have suggested, 2024 textbook also says there is no role of steroid. The outcomes are not different giving a steroid. Now, the question is, some people have given and they've experienced a good outcomes. The thing is, the diagnosis could not have been helped. Perhaps it could have been an additional factor of TMA that has helped that woman recover well. Because if that TTP-LP is causing this feature, maybe the woman has come out successfully well. So maybe we are not on the proper, analyzing things is graded. If we have to put, but we might have some time or the breathing time to say that a steroid, if given, might not deteriorate a condition. If sepsis is excluded, it might give at least a scope to understand that woman may come. We have a little scope, may have.
So some people have done it and they have experienced better outcome. The reasons being two, because they have given almost 30 milligram intravenously or 10 milligram intravenously, maybe 3 times a day. So the reason being, first and foremost, is the fetal lung maturity that has helped. Secondly, it has only, arrested the progression of the disease for that particular period, that is maybe around 24 weeks, because once you diagnose HELP, you have to deliver, right?
Yes.
So in that particular time, if the progression is arrested for that particular time, maybe that can help you deliver or make an attempt to deliver better in a little stable condition. I think that's all. Otherwise, evidence doesn't support giving steroids as a treatment for HELP. So hospitalization, intravenous lines, as we already said, that, you send the lab investigations, do cross-match, catheterize, do all the assessment and give steroid administration. That is only, as we said, empirical. Transport to tertiary care center, platelet transfusion, you have to keep ready, because you have to every 24 hours, maybe you have to investigate, repeat it again and again, see that 70,000, 50,000 to 40,000, 20,000. If it goes, very fast, sometimes over 12 hours, it goes down very rapidly. And also the bilirubin rises rapidly. So that is how you may have to keep a watch, and of course, keep the platelet transfusions ready. So role of steroids, I have already talked about. This is said that it is not curative, but may create a window of opportunity for intervention before maternal condition deteriorates. That is what is the only here. So ultimate management, somebody can say it up, and I think we will sum up. We have discussed two important cases. Dr. Girija has delivered the talk on eclampsia so well that maybe we don't need to even revise it again. So somebody can talk about the just the management, how you can go for this.
After 34 weeks, it is very easy because that decision is easy, immediate delivery, which is we can. But the problem happens between the 27 weeks to 34 weeks. Each and every day counts, and we have to monitor the patient and maternal condition as well as the fetal condition in the hope that everything is fine. But every day we have to monitor, and anytime we may have to take the call if the patient's maternal condition is deteriorating. Third is, in case she is say 36 less than 27 weeks, again it is high time we have to decide that we may have to terminate the pregnancy. In spite of all the methods, many times early rise in hypertension may have lot of complications for the mother, so we have to counsel maybe it is needed and to save the mother itself.
Yeah, so I would just say that, any comment on the postpartum help have you ever come across? And what do you feel that any specific manifestation this postpartum help has?
Yeah, we have seen postpartum help actually. We do come across, and these are the conditions where differential diagnosis should come to our mind. Whenever help-like features are seen in the postpartum period, because they are suggestive of maybe like HUS sort of thing, or a complement-mediated TTPs, or some such conditions. So I think we have to have our broaden our differential diagnosis when you see features. Yes.
So it is observed that, postpartum health has got more renal morbidity and pulmonary morbidity. The renal failure and pulmonary edema is significantly increased when you have this postpartum health. So that is the worst thing to happen, if at all it happens after a delivery or even a cesarean section, because, you have major morbidity and even mortality. We have very interesting cases here, but because of lack of time, I think I have already forwarded this PPT to all of you. There are one or two additions which I need to do. Of course, this is a standard PPT. All of us have contributed to this presentation, but there are few things which I will be conveying to the organizers also, the organization seniors. So naturally, Dr. Suchitra Pandit, Dr. Alpesh Gandhi, who is the president right now, Dr. Girija, Dr. Charmila, all of us will discuss about IV labetalol, and of course we go ahead with the editing of this PPT. I would just take this humble opportunity to request all of you for all your blessings and support, your precious votes for me as Foxy Vice Presidential candidate from West Zone for the upcoming elections, and I request you for the same. The elections are from 1st to 10th August. From West Zone, we have 2 posts. So please make sure that I am your first choice if you feel I deserve. Thank you so much.
Ma'am, just wanted to add, ma'am, these points you always have, that you don't have any anger. You are so soft and listening. Whenever I have approached you for anything, just 1 minute call, you are just away with a lot of patience. You have helped throughout the COVID time. So really, ma'am, I just wanted to thank you, ma'am.
Thank you, my dear. Thank you so much. In fact, it's my privilege to be connected to all of you. I'm so happy that all over India, I've got maximum connect and people love me for my academics and my nature. So I'm very happy and thankful to God for, making me this way. Thank you so much.
And best wishes, ma'am.
Thank you and best wishes, Dr. Sneha. Thank you so much for this wonderful webinar. I think I thoroughly enjoyed the panel discussion, and I also take the opportunity to thank all the faculty, starting from Dr. Anita, Dr. Archana, Dr. Sharada, and Dr. Shanti, and of course, Dr. Girija. Thank you so much. It was a wonderful panel discussion with great inputs from all the eminent faculty here, and best wishes to you.
Thank you so much, Dr. Manjula. In fact, I have initially welcomed and thanked all of you. I'm grateful to OGSH for having me here. Thank you so much, all of you, for your wonderful inputs. Thank you so much. Thank you, Sahiti.
Thank you.
for the
Good night.
participation. Good night.
Thank you all.
Good night.
Bye.
Bye-bye. Bye.
Good night, Girija ma'am. Good night,
Girija.
Sneha.
Thanks, dear. Thank you so
Best
much.
of luck. Best of luck.
Thank you, my dear. Thank you so much. Bye-bye. Bye.
Bye. Bye. Bye.